So, sorry guys, I will just repeat the recap the 5 minutes. Sorry, yeah?
No problem.
So, neurology. The first case is Guillain-Barré. Okay? Guillain-Barré. How can I help you? Presenting complaint. Doctor, I have weakness in my feet or in my legs. The patient will say. That's the presenting complaint. Weakness in my legs or weakness on my feet. Explore. When did it happen? The patient will tell you 2 weeks ago. And as I told you, what is the stem? What is the question? The question is, you are an FY2 doctor in the GP clinic. Linda presented with weakness in her legs. Talk to her, address her concern. So what are the positive symptoms? Weakness in my legs. Explore. Which leg? Doctor's both feet. How did it start? When did it happen? Is it acute? All of a sudden? Gradual? Just before you had this weakness. Have you had any problem? Okay? Then you can ask her, are you able to? Please, this question is very important. Are you able to walk? Okay, I explored the complaint. Now I need the differential. Dr. Lamia, maximum 4 differentials. Maximum 4 differentials. Be natural. Be natural. How can I help you? Weakness on my feet. First differential, stroke TIA. Do you agree? Weakness. Second, multiple sclerosis. Third, myasthenia gravis. Fourth, limb ischemia. Thank you very much. No more. Natural. So weakness. Any weakness anywhere else in your body? Arm, slurred speech, no doctor. What's that? Stroke. So that's the first differential. Stroke. And I can even directly ask, have you had any strokes or any strokes before? Second differential. Myasthenia gravis. What is the question?
Progression towards the tiredness towards the end of the day.
Guys, usually myasthenia gravis, the pain or the weakness, whatever, by the end of the day. So ask about the timing. Doctor, she will tell you it is the same all the time. It's not more at night. Is it more at night? One question. Is it more at night? Does it increase toward the end of the day? No, doctor. Myasthenia gravis. Third question. Limb ischemia, any pain? Pain? No, there is no pain. Limb ischemia is pain. Limb ischemia equal pain. Plus the other pallor and other symptoms you can examine, but no examination yet. Okay? What else? Fourth differential. So limb ischemia. What is the question for multiple sclerosis? Any eye problem? Yeah? Any problem in your vision? Problem in your vision? Yes? What else in myasthenia gravis, in the multiple sclerosis? Yeah, and it comes and goes. It's episodic. But this patient will tell you, started 2 weeks ago, and that's it. It didn't go. But multiple sclerosis, on, off. Okay? So, by that, I made my differentials. Please, no more. After exploring the presenting complaint, and after asking about the differential, what is the strongest question? What's your main concern? What's your main worry? What's your main concern? What's your main worry? Concern. After asking about the concern, I will go to P2. P2. Have you had any problem in your limbs before? Or have you had this problem before? Presenting complaint. What is the second question in P2? Medical condition. What are the medical conditions you would like to ask about directly? Stroke, mini stroke, diabetes, because diabetes can lead to weakness and numbness, yeah? Stroke, mini stroke, diabetes. Fair enough, okay? So P2 is, have you had this before? The second question, medical condition. What are the medical conditions? Stroke, mini stroke, diabetes, okay? Now, DESA. What is P3? DESA. Is it important for you to ask diet here? Diet. I wouldn't ask diet. I wouldn't ask diet. Exercise. I wouldn't ask exercise. Smoking and alcohol, yes. Smoking and alcohol, yes, because alcohol can lead to stroke.
Vitamin B12
Stroke can lead to alcohol. Yes, alcohol can lead to neuropathy. And do we know that diabetes can lead to? But if you ask the patient and no other symptoms, The patient is not going to present with weakness because of diabetes. You understand? But the patient can present with eye early diabetic changes, but not nerve. Okay? So smoking and alcohol. Clear? Please don't go into too much data and too much differentials because you will get carried on, and by the time you start management is like 6 minutes. Then maftosa. Are you on any medications? Allergy? Family history. Is it important?
Yes.
It's very important, yeah? Family history, because we will know that Guillain-Barré is autoimmune and it can be family history there, yeah? Travel history? Travel? No. So, medication, allergy, family history, and that's it. Well, you can ask, it's been there for 2 weeks. It's been there for 2 weeks. How is that affecting your life? You can ask.
Can you ask about diarrhea?
You can ask, but I'm saying be relevant. Medication, allergy, family history, done. Okay, now, what is missing in my history? Now, I'm trying to exclude Guillain-Barré. Yeah? Now, what is missing in my history? It's missing in my history because not only I need to diagnose, but also I need to find the cause and the complication. Am I clear? So now, so far, I was trying to make sure it's Guillain-Barré. But in my history, there is nothing to do with the risk factor and the complication. And I need to know about risk factors and the complications. So, you need to ask the patient had what? Upper respiratory tract infection. When?
1 month ago.
4 weeks ago. So that's the risk factor here. So, has anything significantly happened, or have you had any illness recently? Yes, doctor, that's the first risk factor. Upper respiratory tract infection, which will be viral. Risk factor. What is the complication of Guillain-Barré? Complication, we are always worried about going to the chest muscles. So always ask about breathing, yeah? And shortness of breath, clear. But by the way, it goes and it will go, and it's, Guillain-Barré, it's, ascending paralysis. So it will go up. Clear? So Guillain-Barré will go, it's ascending paralysis. Alright? So ask about shortness of breath, difficulty in breathing, and when the patient tells you that 4 weeks ago I had like sore throat, I had some viral infection, then you can ask, how was it managed? Doctor, it was viral. They did not give me any antibiotics. And that's the history, please, relevant history. That will take from you 3.5 minutes, 4 minutes.
So symptoms, risk factors, and complications.
That's it. Symptoms, risk factors, complications. Okay, now, maftosa, not all of it. Some of it, MAF, and that's it. Okay? Now, would you like to examine? Yes, you will examine, but examination is verbalization. So when you examine, it's just verbalization. It's just verbalization. So verbalize examination. How do I verbalize examination? How do I verbalize examination? Guys, you don't need to say, I will ensure privacy, I'll have a chaperone. No. Either I should examine you or start by checking the observation and
Neurological examination.
and I will do neurological examination. They will check the reflexes, okay? Alright? So basically, you will just verbalize examination and right away you will move into provisional diagnosis. What is the provisional diagnosis here? It's autoimmune condition. What is the provisional diagnosis? What is the provisional diagnosis? Autoimmune. How do I describe any autoimmune condition? The body defense mechanism attacks its own. That's it? Yes? You don't need to go into too much details. Autoimmune condition, the body defense mechanism attacks its own. That's it. You don't need to go into too much details. Okay? Now, management. Where are you? Where are you in the question? You are in the GP clinic. Guys, there is a misunderstanding here that you all make. Management. How would I manage this case? How would I manage this case? Okay. How would I manage this case? Management? How many steps do you have? 7 steps. Always follow the 7 steps. How do I manage? But before I refer to the A&E, what do I want to do in the GP clinic? Take blood? Yeah, this is now the misunderstanding. Okay? This is the misunderstanding here. If there's an urgent case, where you will refer to? you do not take blood in the GP clinic. Why? Because I will take the blood in the GP clinic
Too late.
and I will send it to the lab, which is not in the GP. By the end of the day, the result will come to me. They will process the result, and I will ask you to come a week later to discuss the result. No. In that cases, whenever you're gonna refer any patient with urgent condition, immediate referral to the A&E, you say, I will immediately refer you to the A&E where they will talk about management. Where they will. Why? Because any urgent case, you don't do anything in the GP because the GP clinic is blood and result come. The cases of the GP clinic are the cases, Dr. Alamia, that they say 55 years old has been to the Allman clinic a week ago. They took some blood. Today he's coming for follow-up. This is the GP. They took the blood, come a week later. But any urgent case, hospital, where they do everything. Clear. So the management in this case, what is the management? Okay, management, immediate referral to the hospital, immediate referral to the A&E, immediate, yeah? Where they will take investigations. What are the investigations? The routine blood to exclude infection markers and everything, plus. What are the tests? Lumbar puncture, yes? So lumbar puncture will be done, but there is 2 other studies or things that will be done as well. Muscle and nerve, yeah? Muscle and nerve. So nerve conduction study. And what else? What is in the muscle? EMG, electromyography. So electromyography, it's basically needles will be inserted into the muscle, okay? And they need to see the reaction of the muscle to the nerve. And nerve conduction study. Always understand, it is muscle and nerve. Weakness where? The muscle. She's coming with weakness in the muscle. So muscle and nerve. So nerve conduction study and electromyography and lumbar puncture. Plus routine blood. Okay? Clear? That's why you remember. If you remember in this case, muscle and nerve conduction studies, we'll do some studies for to check the nerve conduction, and also your muscles. We'll do some tests on your muscles, plus lumbar puncture. I will take a sample from where? How do you explain lumbar puncture?
From there.
Yes, it's a procedure to take some fluid from
From the back.
the surrounding of your spinal cord. That's it. Simply. Okay? So these are the investigations. What would they give? What would they give? Steroid. Okay, what else? Immunoglobulin, guys. IV immunoglobulins. Because I said to you in the professional diagnosis, it is autoimmune, so immunoglobulin. Autoimmune, immunoglobulin. Just words to remind you of, so immunoglobulins. So immunoglobulins will be given directly into the veins, IV, okay? And there is another process that we can do. Something else is plasma exchange, which is called plasma pheresis. But always explain it. Plasma exchange, okay? Plasmapheresis. Other treatment, painkiller, because the patient may be in pain, the patient is having weakness, so you can give painkiller. Okay, safety netting.
About any respiratory symptoms.
Breathing. Yes, and swallowing. Yeah, breathing and swallowing. Muscle. Okay? And it's ascending paralysis, it goes upward. Okay? So guys, this is the Guillain-Barré. So Guillain-Barré, remember one thing, Guillain-Barré, patient is coming 2 seconds. Patient is coming with weakness, stroke is differential, stroke and TIA differential, limb ischemia is differential, and myasthenia gravis, the timing, multiple sclerosis, the eye, okay? Alright? Normal history, but the cause of Guillain-Barré is upper respiratory infection, so always ask about the viral infection. She had viral infection. Be careful because we also look for the complications, chest, swallowing, other muscles. So the rest of the history, when you examine, neurological examination, observation, when you give provisional diagnosis, it's autoimmune. By that, management, immunoglobulin. Okay, and because it's a muscle, so investigation, nerve and muscle, electromyography and nerve conduction studies plus
LP.
lumbar puncture. Safety netting,
Breathing.
swallow. Next station. Guys, would that be fast for new doctors who will watch such?
No, no.
I mean, bear in mind that this is coming after. After inductions or medicine structure, counseling
It's
instructions,
fine.
and I'm following notes for them, so it's gonna be video and notes at the same time, the same order.
It's
Sure.
fine. Yes.
So it's not gonna be fast for them,
No.
because I don't wanna feel that I'm doing it for people who know Lab 2 and then others maybe won't be that will be like D12 for them.
No. It's fine. It's fine.
Management to fits, first fit. Okay? First fit. The question is, a patient who presented with a fit for the first time, male, female, age, I don't care. Okay? But make it adult, because I will tell you some things about children. So make it adult, like 25, 30 years old, they present with the fit for the first time. Leave the script. Is it medicine or counseling? Medicine. So which structure I will follow? Medicine. How can I help you? Doctor, I had a fit. So P1, P2, P3, maftosa. Clear?
Clear.
How can I help you, doctor? I had a fit. And he might not say a fit. He may say, doctor, I felt that my body is still, okay? Doctor, so he might not say a fit, the word fit, okay? So explore. Don't just say, oh, it's the fit for the first time, this is the station, no, okay? So he might say, I had jerking in my body. So in any way you will say it, try to explore. So when you explore the fit, how can I help you? I had jerking, I had whatever, I had a fall, I had my body was, twitching. How to explore? Before, during, after. Before, during. So during this incident, what happened? Did you have a fall? Did you bite your tongue? Did you hit yourself? When did this happen? Just before this happened. So this is exploring the fit. Is during the fit what happened? Before the fit what happened? After the fit what happened? So during, before, after. During the fit itself, when did it happen? During the fit, did you bite your tongue? Did you hit yourself? During the fit, did anybody witness it? Yes, doctor, my wife witnessed it. What would you say? What did she tell you? During. Before the fit. Before the fit. Before the fit, what are my differentials? Because during the presenting complaint, I will throw differentials. Before the fit, what differentials? Before the fit. Yeah, very important question. Did you lose consciousness? But before the fit, I need questions to give me differentials.
Did you take your meal?
Before the fit, number one, could you be hypoglycemic? So, your meal. What else can cause the fit as differential? Can it be head injury? Falls? So, fall or injury, head injury. What else before the fit? Before the fit, it's not dizziness. Before the fit, what else? So head injury is okay and meal okay. Before the fit,
Ear discharge.
just before the fit, what were you doing? What were you doing? You're looking for any risk factor. Okay, so what were you doing? Guys, by the way, you remember yesterday, I was saying to you that question. What were you doing? What happened just before the insomnia? It's very important, okay? So just before the fit, what were you doing? So these are now differential. Hypoglycemic fit, head injury, and you're looking for risk factor. During the fit, after the fit. Again, after the fit, did you bite your tongue? Did you hit yourself? Okay? Same. So I explored about the fit. Now, what are my differentials? What are the causes for a fit? In order to, while I'm asking, before I reach P2. The fit. What is the fit?
Brain.
In the head. So, the head. The head, yeah?
Epilepsy.
Now, head injury.
Head injury.
Okay, so now, look. Now, the fit is in the head. Yeah? The fit is in the head. while I was exploring the complaint, I've thrown some differential, but forget about them. The fit is in the head. So just look for differentials in the head. What is this? Skull, the head injury. Under the head, meninges. Meningitis can cause?
No.
Yes. Yes.
Brother, it does.
Meningitis can cause
Meningitis and encephalitis. Both. Okay, yeah. So head injury, then meningitis. You can ask about any fever, any rash anywhere in your body. No. Then encephalitis, the brain itself, which similar symptoms. Fever. You already asked about fever, infection. Okay. Then the brain itself.
Brain tumor.
Stroke, mini stroke tumor. So stroke, mini stroke, you can ask it directly. Have you had any strokes or mini strokes before? Any weakness in your body? Okay? And brain tumor, early morning headache, early morning vomiting. Okay? Yeah, guys, when I say in my differential, I know, is it meningitis? Is it meningitis? First fit, he will come, how can I help you? Ah, the doctor had a fit, you know. It's not meningitis. So why would I ask about child from life when I already asked about fever? That's my point now. I'm trying the new course to tell them, guys, one question about fever, done. You don't need anything else, just fever. Fever is all the infections. Yeah? So now, I finished that. The head, but I'm not nearly finished it yet. What is this? Mouth. Alcohol, can I repeat?
Yeah.
Yes? For alcohol. So don't forget to ask about alcohol. You understand? So alcohol. What else?
Smoking.
It's not
No.
Recreational drug.
No. Something to do with diet. Mouth.
Diet.
Yes, the diabetes, the hypoglycemia. So now all your differential is in the head. Try to just look at the patient, Dr. Hussam. I will be looking at you in the station. You are my patient. How can I help? Doctor, I had a fit. Did you injure your head? No. Doctor, I had a fit. Any fever? No. Doctor, I had a fit. Have you had strokes or strokes before? No. Doctor, I had a fit. His mouth now. Mouth. Alcohol? No. Doctor, understand? So these are the differentials, the causes for a fit. And that's it. So the fit is in the head. What is in the head? Meninges, brain, skull, you know. Now, but the strongest cause is what happened just before you had the fit. Okay, B2. What is B2? Have you had this before? No, because the question is fit for that first time. Any medical condition? What are the medical conditions that you need to ask about?
Diabetes.
Yes, diabetes.
Stroke.
Yes, stroke, mini stroke,
Epilepsy.
diabetes, and epilepsy as a condition as it is, yeah? Have you been diagnosed with epilepsy? DESA? If you already asked in history about hypoglycemia and the diet and the meal, don't go on to diet what do you eat, because it's the type of food not related to you. Exercise? No. Exercise will be important in the counseling. So I said to him about swimming and things, but here no. Because here it's a medicine. I'm trying to look for the cause. The counseling will be diagnosed, but I'm trying to safety him about things. So here no. Smoking and alcohol? Yes. Smoking and alcohol? Yes. Okay? Then maftosa, medication, allergy, family history. That's it. And family history of what? What would you ask about? Family history of?
Epilepsy.
Epilepsy. Okay? And that's it. Don't ask about travel history. Don't ask about how this fit that you had an hour ago affected your life and your daily activity and your relationships around you. It's acute, just one fit. So that's it. History is finished. 4 minutes. Okay? Now, management. What would you do? Management. What would you do? Management in this case. No, the guy is not in a fit now, yeah? He's fine. He said I had a fit. Management, think about it. He had a fit. So this patient, he will be referred, just think with me now, so to get the management like, you know. This patient in a GP clinic, is it my specialty? This patient will be referred. So my job is I will tell him you will be referred to the brain specialist or epilepsy clinic. There is clinic for epilepsy, yeah? Where they will do investigations. Straightforward, the investigation will be CT scan. A scan on the head. Yeah? Is that me? I'm going to do the GP surgery? So I will tell him, I will refer you to a clinic specialized in this, or to a brain doctor, or where they will do some investigation. And the investigation, one of them will be, guys, CT scan, MRI. Yeah, I'm just like, guys, I'm trying to give you the broad line. Just I'm making a map now, but I'll go in details. Yeah, map. But now my job is what? My job, Dr. Lamia, is if you have fit again before the referral, what to do? Nothing will be put in your mouth. They will put you in your recovery position. Who's looking after you at home? We can, we can speak to them about. We can give you a lift. You understand? What else? I'm gonna have my job. If he's driving, what else at home? If there's any sharp things in the furniture or something, because he may have a fit. So your job is talking about things until he gets managed by the specialist. No. What would you examine?
Neurology.
No. He's fine. He's gonna, he had a fit and he's okay. How are you talking? He's not in a... So, my point is, think about it like this. Am I gonna do anything to him in the GP surgery? Am I gonna diagnose? No, he will be referred for electrical activity of the brain and, ECG for the heart, for any clots. It will be my CT scan, MRI on the brain. But my job is the talking, the T-ball. Brother, until you get referred, brother, if you're driving, okay, if you do any exercise, if you go swimming, please don't until you be referred. And who's with you at home, because we need to give you general advice. If this happened at home, this is my job. Do you understand the management map? So, the management is urgent referral within the 2 weeks period. In this case, you will be referred. Because I'm worried about epilepsy. Because this patient, epilepsy is a condition that I need to find out what's happening, because this patient, it is a life-changing condition. He will be referred, but there they will do investigation. Where you do it in the GP clinic? No. Where they will do? What will they do? They will do that EEG. What is EEG? It is basically the electrical activity of the brain. So they will check the electrical. Guys, when I talk to the patient, I always break it down and then say which is called. So, okay? And there they will do CT scan, MRI. Yes, they can. Okay? And routine blood will be done. Anyway, routine blood will be done. Okay? However, our main concern is what? Is from now till you get referred, please, I'd like to give you some general advice. The general advice is what?
Don't drive.
What I told you. Do you drive? Talk about driving. What exercise do you do regularly? If he's talking about swimming, if he's saying if he could have a fit, for me to. Okay? The exercise. What job do you do? Maybe he works near heavy object, maybe he works, What job do you do? So exercise that he does, job that he does, and driving, okay? And if it happened again, who's there at home? Then you can talk about that recovery position. We can talk to them. We can give you a leaflet. They should put you on your side, okay? And they make sure that they don't put anything in your mouth. They sit and watch if it's a persisting ambulance. Station is finished. Okay? But make sure that the stuff that will be done in management is not your job. So don't go into too much details on them. Too much details is you making sure he's gonna be safe till he goes to that.
So there are three things: urgent referral, lifestyle modification, and investigations.
But the investigation there. You say we'll refer you where they will do the EEG and even they will do ECG as well, yeah? So EEG which is the electrical activity of the brain, CT, MRI, okay? There. But my job now is to make sure you are safe. So, is it okay to have a chat? Because this is chat you have not had before. So chat. Talk to me. Don't tell him, do you swim? No. Do you play football? No. So, what do you normally do in your free time? Open question. What do you normally do in your free time? Well, doctor, in my free time, I go swimming. There is a chance if you have an effect from Now till you get referred, please guys, two-way consultation, yeah? So, what do you think of just not going to swimming? You can do something else, for example. Then, can you please tell me, do you drive? Yes. What do you do for a living? Just a casual talk. Okay? Next station is diagnose the epilepsy. So, is that medicine?
No, come.
No.
So, I will take this structure and the station is Anna, 10 years old. Anna, 10 years old, was brought by her mom. Why? Because she developed a fit, even though she is on medication. But they're not going to tell you in the question, even though. No, diagnosed the epilepsy a year ago. And her mom brought her because she developed recently a fit. Or they can bring you Thompson, Shah, 30 years old, again diagnosed the epilepsy, and they brought him or he come to the GB clinic because he developed a fit. So counseling or medicine? Counseling. Guys, when it's counseling, please. There is no differential. I'm not looking for a cause here. I'm not looking, sorry, for a differential here. I'm not looking for why is he having the fit as a different. No, it's epilepsy diagnosis. I'm looking for risk factor. Why is he developing this fit? So basically, in this station, I will explore the most recent fit, and I will try to find why this fit happened. I'm not trying to find the condition here. It's epilepsy. He's diagnosed the epilepsy. So, please, these stations, I don't know if you feel it tough or not. I used to feel it tough because neurology, and I used to feel it tough. So I don't want you to memorize it because I don't want you to listen now and not read again. I am diagnosed with epilepsy, so use it. I can see from my note that you have been diagnosed with a medical condition, epilepsy. Yeah? How's everything when it comes to epilepsy? How are you managing? This is my start. Yes, doctor, I'm coming because I had a fit. I had a fit 2 days ago. Well, I'm really sorry about that. Can you please walk me through what happened? You see, Dr. Ramia? Walk me through what happened. So now I will explore that fit, the recent fit that happened. Anybody has a doubt? Explore it. How to explore it? So this is exploring the recent fit, yeah? Exploring the recent fit. Explore the recent fit. When did it happen? How did it happen? Okay? During the fit, did you bite your tongue? Did you wet yourself? Where were you during the fit? Did you lose consciousness before or after the fit? Can you please tell me just before the fit? The most important question. What were you doing? What were you doing just before the fit? I'm asking about a cause. What was you doing just before the fit? And now, what are the risk factors that can trigger a fit? Guys, simple. Simple from the previous station. What are the triggers for the fit?
Bright light,
Guys, bright light.
music, loud music,
Guys, alcohol.
skip meals,
Guys, stress. Guys, skipping meals.
lack of sleep,
Insomnia. All these,
screen time,
yes, all the noise, all these are factors. I'm trying to look to exactly just before the fit, what was the cause. So can you please, this is the second question, just before the fit. And what are the causes again? 1, 2, 3, 4, 5, 6. Just before the fit. Noise? Yes. Light? Yes.
stress,
Alcohol? Yes. Stress? Yes. Tired? Yes. Insomnia? Both of them? Yes. All these are causes. Simple stations. I'm trying to find what was the reason for this fit. Now, what is his main concern? He wants to know. Okay, why is he having it? Now I'm trying to find the cause. Okay. What is in this station? Do I need to examine him?
No.
No. But what else can it be a cause of effect in this patient? And I will put it in a separate point. That's how important it is.
Not compliance.
Yes. So can you please tell me how is the epilepsy managed? Think. Can it be that he's not using the medication?
Avoid trigger factors.
Can it be, sorry?
Avoiding trigger factors.
Yeah, a trigger factor is one thing. But I'm saying what other causes for having the fit even though he's diagnosed? Could it be he's non-compliant? Could it be that the medication is changing? Because some medication like sodium valproate in PLAB 1, they cause weight gain and then the concentration decreases. Do you remember this kind of questions? Some medication, they cause weight gain. So what you will use now, you will need to increase those later. So my point is, always ask about the medication. What medication are you on? For how long? Do you go for regular follow-up? And how often do you use your medication? Do you use it as prescribed or not? Because in the station where the little girl, Anna, her mom will be thinking that she should give her the medication only when she has the fit. Or after having the fit, doctor, I didn't know that I should give it to her regularly. So always medication, ask about how is the condition managed. How is it managed? What medication is she on? How often does she use the medication? And explore. Now I covered everything to do with the causes. Whichever cause you find, whichever cause, it's counseling. No differentials. No, you are trying to find the cause and it's just counseling station. Whichever cause you found, now I want to manage. Do you need to examine the patient?
No.
Tell me, or I should examine. I had a head doctor. All the exams. I'm diagnosed with epilepsy. If you want to really be safe, it's just like, did you injure yourself when you had the fit or the fall, but nothing to examine. Now, what is the management? In this case, how do I manage? Sorry? I will advise about the risk factors. That's number one. So A is for arms. Arms. A is for advice. R for risk factor. So always advise about the risk factor. Okay? A is for advice. R for risk factor. What risk factor should I advise about? Whatever they're gonna give you different risk factors. Okay? They're gonna give you like maybe I missed my meal, maybe lack of sleep. M stand for medication. Yeah? The second M stand for MDT. This patient, you may, if you don't find the risk factor and he gives you like multiple attacks, you may need to refer him to the specialist. MDT, yeah? I said A, advice, R, risk factor, M, medication, M, multidisciplinary team, S, safety netting. So in the A and the R, you know, whichever risk factor they give you, try to address. With the M, medication. Medication. If the patient, which he will be on medication, not using as it was prescribed, you can review that medication. If he's using for a long time, not to change it, you can review the medication. M, you can refer him to the multidisciplinary team, okay? Neurology and safety netting. What is safety netting?
The risk factors and
No. The safety netting is no risk factor because I've already spoke about the risk factor in A and the R. No. The safety netting, guys, again, the lady who doesn't know that the medication should be given to her daughter, or can you please walk me through Anna's lifestyle? What does she like doing?
swimming, driving.
What about her exercise? Please don't talk about everything. No time. Talk about the relevant. Rather than saying, does she swim? No. Does she play football? No. Does she? No. What does she like to do in her free time? Doctor, she does, for example, swimming. Talk about swimming only. Doctor, she goes usually to the birthday party. Talk about the flashing, whichever she is doing, not everything, yeah? What else? So safety netting is what she does. What else in safety netting? Again, do you know? Has anybody, don't tell her if Anna has a fit, do so and do so. No, ask her. Has anybody told you what to do when Anna has a fit? No, doctor. Then speak. Yeah, they told me to put her on the recovery position, put her on her side, nothing in her mouth. Do not talk about it. If she told you, no. So only if she doesn't, okay? So recovery position as safety netting, okay? Do you want to talk about driving?
No.
Anna's 10 years old. Don't talk about driving. Do you want to talk about alcohol? No. Anna's 10 years old. But in the case when he's 30 years old, yes, driving, alcohol, okay? So there are two cases, Mr. Sandeep, 27, and Anna, 10 years old. The difference is simply lifestyle, because it's two different lifestyle, adult and young, okay? And the medication, general advice, she can make a diary of what happens, okay? That's it. You can advise her about the medication. If the risk factor is medication. If the risk factor is medication. You can advise her this medication shouldn't be stopped. Yeah? Never stop the medication suddenly. Never give her the medication when she has the seizure, the fit. Okay? Are you following?
Yeah, sure.
Or not? Yeah. Next station. Confusion. Confusion is not a station, it's a stations. Okay? So, do you want to write down the scenarios first? Because it's about 5 scenarios. So you know the stem and the history and everything is the same. Station 1, you are an FY2 doctor in the acute medical department. Mr. George Thomas, 72 years old, was found confused by his neighbors and referred by the GP, talk to him, address his concern. So this is the first station. How old? 72. Was found confused by his neighbor and brought. Was referred by the GP to the hospital. Okay? Because it's not a GP station, yeah? Was referred. Confusion is not GP station. Write in brackets. Write in brackets. Confusion due to, that's, by the way, when I say to write in brackets, this is the cause, this is the station. But don't go to the exam, this is, you know, like, this is the station. In brackets is acute confusion because of exacerbation of infection on top of the COPD. So chest infection on top of COPD patient. Clear? So when you take history, COPD, and he developed what? Chest infection. The second case. You are an FY2 doctor in D&E, 75 years old, brought to the hospital by his wife because of confusion. He was diagnosed UTI 3 days ago. So this is confusion due to UTI. He was diagnosed and he was on medication and then he was referred to you. So again, what do you think if a patient was diagnosed 3 days ago UTI and he was referred by the GP? Could it be the antibiotic wrong? Could it be he's not compliant? Could it be? So I want you guys to understand the question. Some of you talk to the patient as if it's new. No, he's been referred by GP. So use it. They give it to you to use it. I can see that your husband was referred by the GP because he had the urine infection. Yes. What happened? What medication was given? Was he using it as it was described to show them that I understand what's happening? Because the fact that he's coming, even though he was diagnosed 3 days ago by the GP, maybe he's not compliant with medication. Do you understand me? So be realistic. That's not new presentation. Okay? The third station. 82 years old. 82 years old. Martin. Admitted. That's the third, yeah? Yeah. Presented with cough and shortness of breath. cough and shortness of breath. And he's confused. What is the station?
Cough, shortness of breath.
Yes, that's pneumonia. So sepsis again. The last station, so now it's UTI, now it's pneumonia, and it's all sepsis, pneumonia, UTI, and infection on top of that, COPD. The last station, electrolyte. You are an FY2 doctor in the A&E, 82 years old, admitted to the hospital. He's confused now. Blood tests, some of them were done. Some blood tests were done, and they gave you the blood test, sodium 115. Hyponatremia confusion. والله استخدم. احنا recording يا برافو. What's your name? so 115. Okay, so sodium level 115. The fifth station, so we collect all the confusion, but the fifth station is not medicine. I consider it as medication. A patient, 71 years old, presented to the GP clinic with memory problem, okay? And the patient has been diagnosed with urine incontinence on oxybutynin.
Delirium.
So that's a patient who's quite having memory problem and delirium, and the cause is medication side effect. Let's not discuss it now. That's not our topic. Our topic is the first 4 stations that are medicine. The first 4 stations that are medicine. Dr. Raja, can you recap the 4 stations? What are the causes? Yeah.
So first of all,
No, just the headline.
diagnosis.
Yeah, the first one.
So confusion with the chest infection and on top of
On
COPD.
top of COPD. Second one.
Confusion with the urinary tract infection.
Urinary tract UTI. Third one.
Confusion with the hyponatremia.
Hyponatremia. Fourth one.
Confusion with
Chest infection, pneumonia.
Yeah. Confusion with the confusion
With
with the
pneumonia.
memory problem, and oxybutynin is the cause of
Yeah, and confusion with pneumonia. So,
with pneumonia.
what are the now these are the stem, guys. Yeah, that's the stem. Now let's go to the station.
One person, sorry,
Okay.
disturbing you. Oh, fine.
No, you know why? After.
Sure. Go ahead.
So, just is it medicine or counseling? Medicine. How can I help you? I'm talking to the daughter or the father or the sister. My mom is confused. My dad is confused. So medicine. So that's confusion, yeah. Now I give you the stem. You know the stem. That's all the stem for confusion. How can I help you? So P1, P2, P3, maftosa. You are always talking to a mother, a father, a daughter. So always confirm identity. Full name, date of birth of the relative, of the person, of the patient, and the name of the relative. So if I'm talking to the daughter, I would say to her, what's your full name? What's your dad's full name and date of birth? Clear? Now, P1, what is the presenting complaint?
Confusion.
Doctor, my dad is confused. I feel that my dad is talking nonsense. Talking what? Take it now aside. The phrase of talking nonsense, I will hear it in one more station apart from confusion. Encephalitis. Drop it now. Just have it like this. Nonsense. Talking nonsense. It will be in a case of encephalitis as well. Anyway, back here again, so you don't get confused. We are talking about confusion. So P1, how can I help you? Doctor, my mom, my husband, my father, whatever, is talking nonsense. Or confused. Or confused. So talking nonsense or confused. If I am gonna be talking to the patient, if there is a patient there, what are the first 5 questions I will ask the patient? I will ask the 5 questions. Can you please confirm your full name, date of birth? Do you know where you are? Do you know who going to here? Do you know who I am? What if I'm just in the cubicle talking to the daughter? Do I ask you 5 questions?
No.
Please, did you ask your dad his full? No. No, I will just be talking to the daughter or the son. Tell me, when did it happen? How did it happen? Did it happen all of a sudden? Has he had this before? And when you say talking nonsense, what do you mean by talking nonsense? So I have discussed 2 scenarios, little scenarios. What are the 2 little scenarios? I said, if you go to the cubicle and there is a patient who's confused, there is a
Patient.
how would you start your station? Can you please confirm your full name? Can you confirm your date of birth? Tell me who I am, where we are, who brought you here. These questions are called the cognition question. For me to confirm he is confused. However, if there is no patient and there is only daughter or son or wife of someone who's confused, do I ask her the questions? No, I will just take it. Why would they bring the relative or the confused patient to take history? Because confused patient will not give you. So when they say talk to daughter, so she can give you history. So, how can I help you, doctor? My dad is confused or talking nonsense. So, explore. How to explore, guys? Since when? How did it start? All of a sudden? Just what do you mean by talking nonsense? Just before this problem happened, can you please tell me anything significant happened? Normal presenting complaint, explore. After the exploring the presenting complaint, what to do? Differential. Yeah? Differentials. 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 Differentials for confusion. What are the differentials for confusion? I am in front of you now, confused. What can be causing confusion for me? Guys, head to toe. Head to toe completely. Can head injury lead to confusion?
Yes.
So, has he had a fall? So, it's a head to toe. Okay? So, any fall, head injury. Then under the skull, meningitis, of course. Any fever, and that's it. Do I need to ask more? Fever, no meningitis. Yeah? Then go to the brain. Again, brain infection, encephalitis can lead to confusion. Yes, but excluded by fever. Can TIA and stroke lead to confusion?
Yes.
So you can ask when you reach the brain, what can happen in the brain? TIA, stroke? Has he had any strokes before? No, doctor. Then come. What is this?
Hypoglycemia.
What's this? Mouse. So what can happen in the mouse? Can I drink alcohol? Yes. Can I... Okay, medication side effect, yes. Can I drink alcohol? Yes. Can it be vomiting?
Yes.
Yes.
Why?
Electrolyte.
Because of electrolyte imbalance, hyponatremia. So, vomiting. Okay? Go down. Chest? Chest infection. I love 2 things, water and air. Yeah? So, chest infection, that's the air. UTI, water. So, 2 things, water and air. So, chest infection, any cough, shortness of breath. Then, go to that. What's underneath of the system? Abdomen. Vomiting, diarrhea. Vomiting, I've asked vomiting already. So, diarrhea. Can diarrhea lead to confusion? Yes, got electrolyte imbalance. What else? Vomiting, diarrhea, and what? Constipation? Can constipation lead to confusion?
Yes.
Slab one question. Slab one question. Constipation can lead to confusion, yeah? So ask about vomiting, diarrhea, constipation. Then go to the urine. Painful pus in urine, UTI.
Yeah.
Changing the color or smell of urine, so UTI. Clear? However, be smart. Because now I'm focusing on to, sometimes you use the structure wrong. How can I help you? Doctor, I have cough and I'm a bit confused and know myself. Okay, wait a minute. We're gonna come to the cough now, yeah? Did you injure your head? No, doctor. Any fever, shell from that? No, doctor. Any stroke or stroke? No, doctor. You vomit? No, doctor. Seriously? No. Cough? Yes, doctor. Cough. Explore. When did that happen? How did that happen? Sputum, blood, this, that. Shortness of breath. Now I know. Chest. I know chest. One more system we need to ask. UTI. Now you covered. You want to ask anything else? You can. But you covered. Chest and urine. Move on. P2, P3 maftosa. You understand? You're not gonna be stuck and head to toe and wait and you have valid differentials, so no. Okay? So be smart. How can I help you? Doctor, my dad is confused. Talking nonsense. Okay, can you please tell me what is the complaint? Confused. So, what do you mean by confused? When did it happen? How did it happen? All of a sudden or not? And then I will start mine. Just before he had this confusion, did he complain of anything? Yes, Dr. Penal pass in urine. Wait a minute. Any head injury? No. Penal pass explore. When you explore penal pass in details, urine color, urine smell, everything, you can go to that. Apart from this, any other symptoms, like what doctor, like, is he coughing, for example? Did he complain of any shortness of breath? Any fever? No, that's it. Quick. Then you have other things you have to manage, you have to examine, you have to, Then differential is finished. But be careful because I have mentioned all the causes of confusion in one structure. In one structure. However, there is a section called hyponatremia cause of confusion. I put it already in the head to toe, but in hyponatremia causes of confusion, it's the same differential. But what? Vomiting, diarrhea. If the patient is in the hospital admitted, and fluid overload, because when the patient is admitted, and the FY1, fluid every day, fluid. So it's like you have 1 spoon of salt in 10 liter fluid. Will it be salty? No, that's hyponatremia. So fluid overload. So be careful because within these differentials, we already covered hyponatremia as a cause of confusion. Guys, are you lost? Because hyponatremia causes confusion. If the sodium is low, the patient will be confused. But what can make the sodium low is the vomiting and diarrhea, is the electrolyte imbalance, which we spoke about it in the structure, okay? So, after the differentials, P2. P2, what is P2? Has he had this before? Any medical conditions? Okay, if I tell me 3 medical conditions to move on. Stroke, mini stroke, diabetes. Stroke, mini stroke. Diabetes, what's her name? Sarah, yeah. Stroke, mini stroke, diabetes. So, 3 conditions as a medical condition cause of confusion. P3, DESA, diet, exercise, smoke, alcohol. Are you really concerned about diet?
No.
No, guys. No, diet, no. Does he do any form of exercise? Your brother is confused. Your brother is confused. Exercise, what? 80 years old, your brother confused. بيلعب belly or confused. So, please don't ask diet and exercise. You can go for smoking. Yes, he can be 80 and recreational drugs. Can it cause confusion, recreational drugs? Recreational drug can it cause confusion? Yes. So ask about smoking and ask about alcohol. Okay? So ask about smoking and alcohol and recreational drugs. But recreational drugs, يعني, like, I'm really sorry, I'd like to ask some question that may sound quite odd. I'm sorry about that. Okay? Does he take any recreational drugs? يعني, show that you are embarrassed, like. Okay? So, maftosa. What is the most important question in maftosa? Here, medication. Because medication side effect can lead to hyponatremia. And hyponatremia can lead to confusion. In fact, in hospitals here, whenever a patient is confused, it's mostly medication side effect. What are the medications that can cause hyponatremia? And in terms of hyponatremia, it will cause confusion. Most common medication. AC inhibitors. So AC inhibitors, the medication for blood pressure, yeah, it causes confusion. Plus everything else, citalopram, yeah, you understand? So can cause hyponatremia. Whenever you say, what is the most common citalopram? No, it's not. It's AC inhibitors. But because citalopram is for our blood purpose, we say citalopram, So it's AC inhibitors, guys. Yeah, AC inhibitors, medication for blood pressure, all of them, angiotensin receptor blockers, all, and citalopram. Okay. Travel history. Would you like to ask travel? Okay, how is it affecting his life? And no. History is finished. By the way, I'm focusing so much on how to make your history short and yeah, that's what I want. Short. You understand? So
Social history. Social history.
social history, but not how is it affecting. Maybe who
do you live? Who's taking
does he
care?
live with? Who's taking care of him? But not how is it affecting his life. You can ask social history is 8 years old. Who's looking after him? Yeah. How many stations we said? How many stem we said in this question?
5.
5.
5. One of them is medication.
Yeah.
I said the patient is oxybutynin. Yeah.
Yeah.
That's a medication side effect. A medication that causes the confusion. Okay. And 4 of them are medicine. One of them is COPD. One of them is UTI. One of them is pneumonia. Okay. There is a 6th stem. Another question. I'm sure all of you know it. It's over the phone. They are asking you to talk to the nurse to take history from her, but she's in a care home. You're talking to someone, to a nurse, in a care home. You understand?
Yeah, I understand.
To take, she's the one looking after a patient who you have now. So there is no patient here. There is what? Over the phone. So write down 6th scenario of a station of confusion. Right? It's a phone consultation. You are an FY2 doctor in A&E. You've been asked to call Anna, to speak to Anna from the care home, the nurse looking after any patient, the name, any name of any patient, okay? As she is admitted in the hospital now, she's in the hospital, confused. She's in the hospital what? Confused. Then it's a phone consultation. Guys, so you just ring here and can you confirm your full name? Or you ring, am I speaking to that such and such care home? Yes. Can I please talk to such and such nurse? I'm the doctor, okay, from such a hospital. And then the nurse, you speak to her, yes, it's me, doctor. Are you looking after such and such? Can you confirm your full name and date of birth? Yes. And you start taking what? History. But be nice to who? To her, because there is no patient. As if you are talking to, I told you before, confusion patient, they will ask you to talk to relative because he's confused. Yeah. But in this case, she is in care home and you're talking to the nurse, okay? And be careful to address her concerns. One of her concerns, doctor, how is she doing? What did you do for her? Can you tell her? Can you tell her? No, you can't. No, you can't, okay? You cannot tell her. You cannot. You tell the next of 10 years, but you cannot. Yeah, we'll look after her. Huh? We'll make sure she's okay and, but you cannot tell her. Okay? Make sure you don't tell her anything. So take everything from her, but don't tell her anything. Understand? Yeah.
With whom will discuss the management?
Sorry?
With whom
With
will
the examiner at 6 minutes. Okay?
What kind of questions that we should ask the nurse?
It's a history. No, it's a history. You are talking to the nurse as if relative.
Yeah.
You're looking after her. Yeah, what happened? Why, doctor? She started coughing. Since when? How did it start? Any sputum? Any blood? Anything else? Shortness of breath? No, doctor. What about her urine? Any? You understand? No, normal history. You understand?
But no management in this station.
No. At 6 minutes, Bill discuss management with the examiner.
With the examiner.
Such questions. You cannot tell her management.
Yeah.
You cannot speak to her about anything. Okay? So make sure you don't tell anything. Yeah? Don't tell her we'll do this, we'll give her to this. No. Okay? And very important question, make sure you ask the nurse, does she have any end of life wishes, any DNR form in place? Ask this question. Doctor, what's your name, doctor? Because when I said it, you were thinking, what? You know why? This question or not? You know why? Because if the patient is having don't attempt her active resuscitation, you will need to see that should I give her, if she feels ill, like do CPR, that's why it's It's a question that just makes you look, and asking about the next of kin. That's an extra, some questions to ask next of kin. You ask the nurse, the next of kin, and ask the nurse, does she have uniform in place? Okay? And what else you can ask the nurse apart from the history of our medicine?
Who's gonna have this?
Yeah, I mean, who before that, how was she? And is anybody else sick in the care home? Maybe there's someone else. Maybe it's contact. Okay, so why do we have the nurse, Dr. Ibrahim?
To ask her what's the history.
Okay, let's talk about it.
And if there is anyone else.
Yeah, no, I'm saying the nurse is as if she is relative. But do you tell her anything?
No.
Take from her, but don't give her. Be selfish. Take, and then give. Sorry. Now, what is the management in confusion station? Obviously, we know if it's sepsis and you talk to relative, we know. Verbalized examination, of course. Observation, chest. Observation, And then provisional diagnosis, how to give provisional diagnosis sepsis. How to give provisional diagnosis? Infection that is spread in the blood from whatever, from her water cycle, from her chest. And what is the management? What is the management? Number one, admit. Admit. We'll keep her in the hospital. I'll talk to my senior. We'll run some investigations. What are the investigations? Routine blood and what?
Brain scan.
Blood culture, lactate,
Oh, okay.
and we'll monitor their output.
Yes.
Urea electrolyte, perfect.
Blood sugar.
Blood sugar. When I said blood culture, lactate, urine output, I said take three.
Chest X-ray.
That's the take three. Then talk chest infection, chest X-ray.
Chest.
Urine infection, urine culture. That's are you lost? So it's a take three, give three, yeah? Management is take three, give three. That's the management of sepsis. Take three, give three. Okay? Give three. Take three, investigations. So we'll check her blood, routine blood and blood culture, lactate. So that's the blood culture. That's number one in take three. Lactate, number two in take three. And we'll monitor that. Urine output. Okay. Give three. We'll give her fluids through her veins. We'll give her oxygen. We'll give her antibiotics. And don't forget, I have taken three, yes, but what if the cause is a chest infection? Chest X-ray. If the cause is urine infection, urine culture. So don't forget that you need a chest X-ray or
Urinary culture.
I've said something wrong here. I said or, it's and. Any patient suspecting sepsis, I will do chest X-ray and the urine culture because the patient could have infection in urine asymptomatic. And the patient can have two, not even one. So always chest X-ray and so you can make it take 5, give 3. Take 5, give 3. Take 5 so you don't forget because maybe you mentioned take 3 and you forget. Oh my God, she was coughing. But the problem is that we remember at the door. Seriously, give you back. Thank you. At the door you remember. I forgot the chest X-ray. I swear to God, that's when you remember. Or you remember at the door of the second station. Chest X-ray. Chest X-ray. I forgot. Family history. Then while you were thinking about the previous station, get into the second station. You get in, you don't know the name, you don't know the age, you don't know what, you know? That's, it happened with me personally, yeah? Personally, it happened with me personally.
Oh my God.
I was at the door, I finished my station, I came out, and then I saw at the door. My first station. Seriously, my first station was, that's why in the exam, you prepare, you work hard, you study hard, you practice, you do your best. But there are other factors. There are other factors. I have done my exam, I passed in the second attempt, not the first attempt. So there are other factors. And I studied for 6 months, I prepared really well. But other factors, like one of the factors happened with me on my first attempt. That's why I gave myself as an example and I advise people. I had the first station, anorexia nervosa. I went in, it was my first station, I was quite stressed. And then I went out, but there was like mental block in this case, mental block. It happened for me, mental block in the first case. Then I came out, while I was at the second cubicle, I literally
found the secret.
thought about the first one. Oh, I forgot us about bank. Wow, management. And when she told me what you're gonna do for me, I stopped. I couldn't tell her anything. And I was thinking so much that I only realized, wallahi, I only realized, began, and then I began, and I don't know the question, I don't know the name of the patient in the second station, I don't know anything, because I opened the door and I didn't read the question. That's it. You had the start and then that's it. So my point is, be careful. Once the station is done, it's done. And wallahi, I passed the anorexia nervosa.
Oh.
Seriously, I passed it. Wallahi, I passed it. It's the one that I had mental block and the one that I stopped and the one that the one that I ruined my exam, I passed. You understand? So my point is, switch off. Once you finish, switch off. So, in this station, sepsis, take 5, give 3. Take 5 is the blood culture, lactation output, and the other 2. Urine culture, chest X-ray. Give 3, IV fluid, and you always say, and when you go to the station, the semen or whatever, you forget. I will take all the blood, all the blood. Make sure you focus on what you need. Confusion, sepsis, yeah? So make sure, if you have a patient who's confused, what to do at first. The patient is confused and you're talking to the patient. What to do? 5 questions. To confirm he is confused. Confirm your full name, confirm your date of birth, do you know where you are, who I am, who brought you here. But if there is no patient, no cognition question, because there's no patient. Take history right away. Cause of confusion, we know, head to toe. DESA, not all of it. Diet, exercise, no. Smoke and alcohol, yes. Don't forget that within the causes of confusion, there is a very strongly important cause, which is natremia. Natremia. Be careful, because in hyponatremia, if it's the cause of confusion, there is an extra management. Extra management. Hyponatremia. Sodium is low. Sodium is low. Guys, we finished confusion as sepsis infection. Yeah? You see? Take 3, give 3. It is the stations where sepsis pneumonia, sepsis COPD infection, sepsis chest infection, sepsis. But there is a sepsis. There is a confusion cause of hyponatremia. So do you give antibiotics? No. Be careful with something else here. Here you will basically, if the cause of hyponatremia is fluid overload. If it's the cause is fluid overload, too much fluid with some, you know what the fluid overload? Yeah. The patient was admitted, we give them so much fluid that the sodium level became low. Fluid restriction. What do I mean by fluid restriction? Yeah. No, fluid restriction means that we only give them 1 liter in the whole day. It's called the fluid what? Restriction. What do I mean by fluid restriction? We restrict giving them if the cause is fluid overload. What if the cause of hyponatremia? They are on medication, ACE inhibitors. Stop the medication. Yeah. Clear. Are you lost to the last bit of if the cause of confusion is, because nobody asked me, nobody said to me, brother, you told us 5 questions of confusion, and now you're giving us this. Do we do this with hyponatremia? No. Hyponatremia is confusion, yes. When you take history, is there an infection? no medication side effect, for example, okay, then management is different because it's hyposodium. So if it's a fluid overload cause restriction fluid, if it's decreasing that, you can even give them saline. You understand? So that's something else, okay? What is the sodium level when we say hyponatremia?
Less than 135.
Less than 130?
135.
Less than 135. Guys, less than 125. It's less than 125. We know that the level is 135. We know that. We know that less than 135. We know that less than 135 is hypo. But usually the level that causes confusion is 125 and lower. So usually. So you will never be given a patient who is, when they tell you a confused hyponatremia, it's 115. Can you see? I told you 115.
Yeah.
So usually below 125. However, it is below 125 or symptomatic with any level. What do you mean, Dr. Mo? I could be 130 and symptomatic. Then you need to treat the hyponatremia. So when do we treat hyponatremia? At any level
At any level with
with
symptoms.
symptoms.
Or
At
below.
any level low, like 132, 131, 130, or
One below
less than
one.
125. Sorry?
Going to refer to any this.
No, that's guys. Hyponatremia is admission.
Yeah.
Hyponatremia, we
Okay,
admit the patient. Any patient with hyponatremia will be if he is symptomatic or less than 125. Any patient, admission. And the cases of admission is if he is less than, what if he's 130 symptomatic?
Symptomatic.
Admit. Okay? Encephalitis. I said to you, this is the last station, yeah? I said to you, encephalitis, it's a father bringing his son and he's saying to you, my son is
Acting.
talking
Talking and
nonsense. So a father bringing his son and saying to you, my son is talking what?
Is this in GP
Nonsense.
or
Sorry?
A&E? Is this in GP or A&E?
What do you think?
A&E.
Yeah, what do you think? Encephalitis
Yeah.
case or, sorry?
I mean, if it comes in GP, we can refer.
No, yeah, but it will not come in GP.
Okay.
It's always A&E, yeah? So write down, you are an FY doctor in the A&E. Jack White, 23 years old, was brought by his father because he's talking nonsense. Or, what do you mean, Dr. Mo, or? He can bring it with another presentation. Fit, because of a fit. Can it come because of a fit? Yes, encephalitis fit. Yeah? Yeah. In the cubicle, the vital signs, temperature is high, 38. And oxygen is normal. Not normal, it's like 95. And yeah, but the oxygen, by the way, because I've heard yesterday, I don't know who was talking, one of you guys were talking about, I was gonna correct one of you saying 93 could be normal in oxygen. 93 is not normal, yeah?
94 and
So,
94
if
and
you
below.
check a patient, someone, it will be 97, 98, 95, okay. 94, when it's going down, it's not normal. So 93 is not normal. I heard yesterday, someone and the same man was sitting behind and I was in the back and one of you guys were talking about oxygen. 93 is normal. No, no, normal.
About COPD.
Sorry?
They
No,
talk
COPD 88 to 92.
Yeah, they
That's normal for it. But normal patient, oxygen 93 is not normal, yeah? So, positive finding in this case. So, how can I help you? Doctor, my son is talking nonsense. Is there any son in the cubicle? No. No sons, yeah? You are talking to the father. That's why they bring in the father. Okay? So, is it medicine or counseling?
Medicine.
Okay, So they love this case, even though we don't do much in this case. So the presenting complaint, talking nonsense or having a seizure. Okay, so let's either or. If he said he's having a seizure or a fit, so the presenting complaint is a fit. How to explore it? Before, during, after. If he's having his if he's saying he's talking nonsense, how to explore it? What do you mean by talking nonsense? That's a very logical question. Talking nonsense. What do you mean? He wants his inheritance or what? Because maybe nonsense for his dad. If he's telling his dad, I need my inheritance. So he's coming to you, my son is talking nonsense. But it's not nonsense. The guy wants his inheritance, you understand? So please always ask. Don't tell you, because that's how we think. Yeah, this is the encephalitis station. Nonsense one. This is the other nonsense. No, always, seriously. Always, what do you mean he's talking nonsense? So explore. What do you mean by he's talking nonsense? Doctor, he's saying things, this and that, strange. Since when? How did it start? All of a sudden, has he had this before? Explore, talking nonsense. Talking nonsense. Anything else? Then he will give you the positive finding, which will be fever. Doctor, he seems disoriented, drowsy, which confusion. Now it's confusion. Okay? Doctor is having a change in his behavior. By the way, that's a typical finding where he will tell you, change in his behavior. Dr. Raja?
Yes.
If I tell you my son is having a change in his behavior, what to do?
Tantrum.
Huh?
Tantrum.
What do you mean?
What do you mean?
I will stand here and then he push the table and then tantrum. No. He's lost. I'm saying if I tell you my son is having a change in behavior, what would you react? What would you say to me?
That's what they mean by changing.
What do you mean by changing behavior? Okay? So no, I picked them when he was like thinking about something. It was not here. So change in behavior, change in personality, feeling agitated. Okay, he's complaining of headache. Guys, I've given you all the positive things in this case. So the positive again. Doctor is having talking nonsense, explore. Anything else? He's gonna say fever, headache, confusion, change in behavior, change in personality. Clear? Difficulty in speaking. Now, how to manage encephalitis? What is the management for encephalitis? Yes, I love this start, admit. Seriously. I love that when someone starts with admission, that's the best way. Not like, I will give him this. No. I will admit him. Yes, so, management. Admit. What else?
Investigation.
Sorry?
Investigation.
Investigations. What else?
Symptomatic management.
Symptomatic management. So this patient will be admitted in the ICU. So you have to say it as it is. He will be admitted in the intensive care unit. Okay? And now you start. Why intensive care unit? Because you went, you saw him, you've seen the patient. The patient is having all these kind of things. You examine him. When you examine him, encephalitis, he will be like, guys, dying. You understand? So he's not a case of A&E and no. This patient will be admitting him in the ICU. What if, because I missed the part of provisional diagnosis. How do I give provisional diagnosis? What is the definition of encephalitis?
Infection is a brain.
Yes, but if it was me, to be honest, I would say it's infection in the brain or the covering of the brain. Because I don't really, by this stage,
Maybe
know whether
meningitis.
it's a meningitis.
I don't really know where am I, understand? Then when you go to management, number one, admit in the ICU. Senior, investigations. What are the investigations, guys?
LP,
Guys, the problem is in the brain, yeah? So don't forget CT and lumbar puncture. That's two not to forget. But do you start with CT lumbar puncture or do you need blood? So start it with the blood. We'll take blood, infection marker, blood culture, lactate. Then we'll do scans, scan on his brain, CT scan. We'll take sample from the fluid around his brain. You see, I didn't say lumbar puncture. Because someone will do LB, EEE, CCE, GGE, and they bring the station. And the patient. So please, in management, yeah, you don't need to say chest X-ray. We'll do scan on his chest, scan his brain. You understand? And I see this clearly when you're practicing. So, well, thank you very much for what you told me. Now I'll be doing EEG to G, BBG to G, and you guys, and you know the simulator. Okay, doctor. Anything else? Okay, doctor. Well done. Understand? No. So, for example, if you're gonna talk about EEG, the electrical activity of your brain, for example. If you're gonna talk about ECG, what would you say? Heart racing. If you're gonna talk about just scan your head. Please get used to this. When you talk, just don't worry. The examiner, he understand. He understand that when you say scan on the chest, okay, or image of the chest, he knows. He knows. Image is not gonna. It's just seriously. When you say you will check the electricity of your heart, don't worry. The examiner knows you're talking about ECG. If you are worried, say the electrical activity of the heart, which you call it ECG. The electrical activity of the brain, which you call it EEG. But don't just keep throwing things because you want to finish. No, we're gonna take short history. It's better for me, but make sure that the patient understands. So, management. Step 1, admit. Where?
ICU.
Step 2,
Involves senior.
step 3, investigate.
Investigation.
What are the investigation? Routine blood, plus blood culture,
Inflammatory markers.
everything. Blood culture, lactate.
Take fluid from.
Then, after the blood, we need to scan on the head, CT scan. What else?
Fluid.
Fluid around the brain. Don't say LB, fluid around the brain, which we call it lumbar puncture. Okay, what else? EEG. So, the electrical activity of the brain, which we call it scan or whatever test, EEG. Please, guys, try to listen. Now, the rest of the management, symptomatic treatment. Yeah?
Antipyretic.
Please don't forget, write down in bracket supportive treatment. I love the word supportive. What is the supportive treatment?
Oxygen.
Antipyretic.
Okay?
Anti-painkiller.
Okay? Supportive treatment is the fluids, is the painkiller. Okay? If the patient is vomiting, is the antiemetic. Is the oxygen. Please, guys, yeah? Supportive treatment. When you mention lumbar puncture, you will be given these findings. Lymphocyte 90%, glucose 5, protein 0.6. Okay? And when you mention examination, the examination, observation plus neurological examination, you will be given generalized lymphadenopathy, positive Brodzinski and Kernig's. You're not gonna examine, yeah? Generalized what? Lymphadenopathy. Positive Brodzinski and Kernig's. Breast reflexes. Just verbalize examination. You're not gonna examine. This is not examination station. But when you say after history, we examine. After examination, go back to day 1. But sometimes I just after history, what do? We examine. After examination, provisional diagnosis. After provisional diagnosis, management. So when you examine, when you verbalize observation and neurological, you will be giving positive Brodzinski and Kernig's. You will be giving generalized lymphadenopathy. The patient has infection. That's it. When you say in the investigation lumbar puncture, you'll be giving a paper with this finding. That's it. That's what I want you to know. But you know that's encephalitis, yeah? Without giving anything, yeah? Understand? All of you know it's encephalitis, yeah? You don't give it encephalitis. At the door, nonsense, encephalitis. Understand?
And then when he gives the
It is
paper,
viral. Sorry?
when he gives the paper, we comment on it. We say, I can see the.
Yeah, because the normal level is there. The normal levels are there. Like the protein is high, 0.6. It is there, normal level, yeah? So, and even in the note, the normal level is there, and in the exam, they put normal level and his level, yeah? Yes, so supportive treatment. supportive treatment, okay, and antiviral medication. Antiviral medication through the veins 3 times a day for 3 weeks. That's as if it's a specific medication now. So supportive plus specific. Specific is antiviral, steroids, immunoglobulin. Specific antiviral, they can give steroids, they can give immunoglobulin. But my main concern, you're not gonna jump here. You're gonna do this, but
Just message me.
admit in the ICU. Admit to come to my cell because we need to run some investigations, check the blood culture, lactate, ABG, blood gases. We'll make a scan, perform a scan on the brain, CT scan. We'll take some fluid from the fluid around his head, like what we call lumbar puncture. Then we hold the result. Protein is this, lymphocyte is this is this. Then we can be given further management. But this is gonna be neurology department, yeah? Like what? Like we can give medication for the viral infection as it's viral, okay, through his veins. We may give steroids for that. Brain what? Swelling. I wanted to sound say edema. No, brain swelling. We can give some steroids, and sometimes we can give also immunoglobulins, okay, which is antibodies through his veins. That's it, okay. But the most important thing for me is the supportive. Thank you very much, guys.
Thank you.